Okay, it's 6 minutes past 5. We plan to start at 5:15, but why don't we get going? It's an exciting program, and we will have more time for discussion. So please welcome to Svenska Läkaresällskapet. I'll start in Swedish and then continue in English. Vi har lite grann som tema i år faktiskt multisjuklighet hos äldre, och äldre drabbas ofta av hjärtsjukdom. Idag kommer vi att få höra 3 stycken föreläsare som har specialiserat sig på hjärtsjukdom, varav en ifrån England. Och here's our main and international speaker, Rasha Al-Lamee, who's sitting just in front here. Wave your hand, Rasha. Yeah. Rasha trained at London Sports College, and then with a short dash to Milan in Italy, she ended up at Imperial College. She had her research training under Professor Darrell Francis at Imperial College, and I know that they remain close mentor and collaborator. He remains her close mentor and collaborator. She received her clinical training under Professor Patrick Vallance, who went on to be the UK government chief scientific advisor during the COVID crisis. That's not so bad. Currently, she heads the Lancet Commission for Cardiovascular Disease. And outside her research and clinical practice, she is a senior editor at the journal JACC, perhaps Jack, I don't know. Finally, and perhaps importantly, she is also the leader of the Orbiter studies, which I know she is profoundly, and for good reasons, proud of, where she works hard to offer patients with stable angina the best treatment. And Rasha will start tonight, but we have 2 other speakers. I will present them in due time. First, Johan Sundström from Uppsala and Magnus Bäck from Karolinska Institutet. We'll get back to both Johan and Magnus. I'm extremely happy to have you here. And then we're aiming for a discussion around 6:40 until 7. And for those of you who have registered, there will then be a dinner at the society. And with that, I'd like to thank Svenska Läkaresällskapet, Swedish Society of Medicine, including the funding that enabled us to fund Rasha's visit here. And I'd like to welcome Rasha Al-Lamee to give the first talk. Please welcome.
Thank you very much for the invitation. It's an absolute pleasure to be here. I wish I could say anything in Swedish. I learned, hey, hey. This is about as far as I can get. So I'm here to talk about the Lancet Commission that I led on coronary artery disease. But importantly, Johan, who sits in the front, was one of the key commissioners. And so I'm sure he will be part of our discussion later. So I will say initially that a Lancet Commission is not an easy thing to lead. And for about 3 years of my life, on my notes page on my laptop, along with call the plumber or arrange childcare, was a line that says, do the Lancet Commission. And that line was one of the best lines ever to delete from my job list. But in the process of thinking about a Lancet Commission, I had to think about something in a very, very different way. Because I'm an interventional cardiologist and a clinical trialist, and I'm used to doing procedures in the lab and thinking about clinical trials within the setting of the UK healthcare system or more broadly in Europe and beyond. I'm not so used to thinking about global health problems and how you think about answering global health problems, knowing that all the healthcare systems are very different and the needs of patients across the world are very different. So I'll talk to you a little bit about that process. So what happens first is they call you and say, please, can you come and have a meeting with the editor of the Lancet? I had that meeting in which they said, look, we think there needs to be some discussion around coronary heart disease and that we should do a commission on coronary heart disease because it's an important subject. Do you know what a commission is? Well, I kind of knew something about commissions. I'd seen many commissions before. But what I hadn't really understood about a commission is it's very different to a review piece. It's not meant to be a review of the literature so that you could read it as a medical student or as a clinician. It's meant to be a piece that speaks to people who are not necessarily clinicians, who are public policy makers, who sit in government, who sit in healthcare charities or big funding groups, perhaps even patients themselves, people who think about our healthcare systems. these are the people that should maybe read a commission and think about where they should focus resources or funding. And so then you think, well, how can I do that as an interventional cardiologist? So the only answer was, of course, to bring together lots and lots of commissioners who could bring lots of different expertise. And you can see that we had commissioners from all over the world who were cardiologists, who were pharmacologists, who sat in things like drug development, who knew about healthcare services, who maybe knew about real-world data and modeling, and those who perhaps thought about cardiac imaging and other aspects of coronary artery disease. And then what was important was to put them all in a room and start to think about what we wanted to do. And of course, the next step was to think about the challenge. And when you sit in Europe, you think, coronary artery disease, is it such a big problem? Do we really need to tackle this problem? Haven't we already done enough? But actually, it became increasingly clear that this is still a major, major challenge in our healthcare systems. And I'll start by saying something quite controversial. One of the biggest challenges that we saw was that atherosclerosis in general, whether it's in the coronary arteries or even beyond in other areas of the body, is just considered to be an inevitable part of aging. And many of our healthcare systems are set up to just consider that this is something that we all get at some point, or many of us will get. And even if someone tells you that someone had a heart attack in their 60s or 70s, you'll think, well, that's kind of normal, isn't it? That's the disease that comes as we get older. Even as we sit in clinics and we think of things like coronary calcium scores, we're told to adjust and think about them based on patients' age. And so our whole system is set up to believe that in time, most of us will get some level of atherosclerosis, and we're the lucky one if we just have a bit of atherosclerosis and don't have a cardiac event. And we realized that that's where things were going wrong, that we shouldn't necessarily consider it an inevitable part of aging because it's a preventable disease. And if we look now at the types of patients who present with acute coronary syndrome, what we know is the vast majority, and this data of course comes from the US where healthcare systems are very complicated, but the vast majority of patients who present with a first myocardial infarction will have had no symptoms and be taking no preventative treatment. They will never have seen a cardiologist before they present to my cath lab in the middle of the night with a heart attack. So clearly, there's something around the system that's failing. And importantly, we have drugs that prevent this disease. And what we know is that coronary artery disease is not fixed and not solved, and that the mortality is rising. And our modeler, who was part of the commission, modeled out what would happen to coronary artery disease over time by 2050. And you can see that this will become, it is already one of the major causes of mortality worldwide, but it will become the largest cause of mortality across the world. And when you look at that modeling, you start to really understand how big the problem is. So at the moment, we have 10.5 million deaths globally we have less than 10.5 million deaths globally per year, around 7 million. And you can see what it will become by 2050. We know that there'll be a 4.2% rise in deaths with this disease in upper and middle income countries, so where we sit at the moment. But where it's really going to change is in the lower middle income countries, where we'll see a rise of 19% in coronary artery disease deaths. So all of a sudden, areas where infectious diseases were perhaps the biggest killers, actually it will be acute coronary syndromes that really make the difference. And we can see again that global heterogeneity. So in Europe and the US, we expect the rates of people who die from coronary artery disease to go down in time. But actually you can see that across the world, they will go up. And there's a variety of reasons for why that might be. When we look at risk factors, it starts to become obvious. You can see that the risk factor that's still the most important contributor to coronary artery disease deaths is hypertension, and that will only rise by 2050 because we're pretty poor at diagnosing and treating our patients with hypertension. We know that dietary risks are a real problem, and of course dietary risks are going to become increasingly a problem across the world as diets change. High LDL, of course, a very big problem and will only rise. But we see that public health measures such as smoking cessation and banning smoking from various public places has meant that tobacco won't really increase over time. So in some levels of our system, we've been able to change risk factors, but in others they continue to rise. And what's also important to say is that all of this modelling that we did was based on global burden of disease data. So there are probably lots of risk factors not on that list because they're hard for us to understand. We found it very hard to get any data on low physical activity, for example, but we know that that's probably a contributor to coronary artery disease and that it's probably likely to get worse over time, but we couldn't model that out. What we do know is that by 2050, there'll be some other risk factors that will become evident. So pollution may be a real contributor to coronary artery disease deaths. So might some of our dietary risks, such as sodium intake. But of course, what's really important for those of us who know what we can do in clinic is we will see things like LDL cholesterol continue to be a massive contributor to coronary artery disease and only increase over time. We know also, as I've said, that blood pressure is a big problem and will be continue to be a big contributor. But where we're going to start to see rises in risk factors that are really quite worrying, especially to those of us who are parents, is high BMI in childhood. So that obesity rate in childhood that we're seeing rise across the world is going to contribute in time to coronary artery disease deaths. So how will we make the funders care or the policymakers care? Well, we had to model out the financial burden of this disease because, of course, they might start to sit up and listen. So if we look at that burden of disease now, we know that 27%, around a third of spending on cardiovascular disease sits within the coronary artery disease space. In 2021, that contributed to $1.7 trillion. By 2050, that'll be $2.6 trillion. So this disease has a massive impact on our financial status and it will only grow. And of course, this modelling is very difficult because we don't really have data from areas like Africa, and we probably underestimate the financial burden of this disease based on the many countries in the world where we don't really have the data. So at our best guess, it's here, but it's probably going to be even greater. So now I've kind of painted the doom and gloom story, we had to sort of sit down and think about the objectives. And in doing this, what we did was sit down as commissioners, over 20 commissioners, and put our objectives down. Lots of people wrote them down. We made a massive list of over 70 potential objectives. And then we had to whittle that down together to decide what were our key 10 objectives that we wanted this commission to speak to. And I'll speak to those in turn. So the first was to, obviously, reduce the global burden of mortality and morbidity from coronary artery disease. And we felt this was achievable because, to many extents and purposes, this is a preventable disease. We already have lots of various treatments that help to prevent this disease. We wanted to be able to reduce the personal, societal, and economic burden of the disease and think about how we might do this across the healthcare systems across the world, because as you saw, there will be a great financial burden that will only grow over the years. And because commissions are about research, we also obviously wanted to be able to identify areas of research in the future that might have a real impact on coronary artery disease. And it was important to us to encourage global collaboration, increased investment in the disease, and of course we needed to think about equitable care delivery. So we spent quite a lot of time in the room because, of course, as is often the way, there were many Europeans and Americans in that room. And we discussed what we wanted, and we decided that this wasn't about bringing the top, whatever, 10% up. It was about trying to have global objectives that might bring the whole of the world up. But that's quite difficult because the healthcare systems are different and you don't want to penalise one system based on another system. And how do you ever think about something that will have global impact? So we recognise that different things would have to happen in different places and that the priorities might be different in different regions at any one moment. So then we thought what we must do is provide guidance to the stakeholders to work together towards a common goal, knowing that they might have slightly different priorities in different countries, but that the common goal would be to reduce the mortality and morbidity from this disease. And then we started to think about strategies. How would you do this? And I'll speak to the first of those strategies. So the first seems quite simplistic. It's actually to redefine the disease. So at the moment, in most of our cardiology systems, we would talk about ischemic heart disease. So we speak to the fact that coronary artery disease is only important once there is a mismatch between blood supply and demand. And our healthcare systems are based on us looking for coronary artery stenoses, but only really those stenoses that are limiting blood flow to such that they're causing symptoms in our patients, or perhaps that they're causing obstruction and acute coronary syndromes. Everything is geared towards looking at the end stage of the disease, and we even speak about ischemic heart disease, the end stage, as if the atheroma in itself is not so important. It's only important when it gets to that end stage. And we decided that that's where we were going wrong. We needed to redefine the disease based on its pathology and call it atherosclerotic coronary artery disease, and say it was just as important to pick up atheroma early, in fact, probably more important than picking it up late. Often, much of our system is based on that late stage because that's where we think we can have an impact. But what we decided is we needed to be able to have an impact much, much earlier. And in that, we wanted to be able to propose some updates to the ICD-11 codes, because of course the definitions of the disease also drive the data that we collect, and they drive how we think about the disease. So at the moment, the ICD codes would define acute ischemic heart disease and chronic ischemic heart disease. For the acute, they tell us that that's defined by ST elevation MI or non-ST elevation MI. For the chronic, there are codes that are based on anatomy and clinical presentation in terms of symptoms. But what we decided was that for the acute setting, we needed to think about acute atherosclerotic coronary artery disease and be able to distinguish the mechanisms of action. So for infarctions, there are many different ways that you might have an infarction. The predominant one is from atherosclerotic disease, but there are non-atherosclerotic causes and they needed to be taken out. So for example, spontaneous coronary artery dissection shouldn't sit in the same ICD code as a standard MI caused by atherosclerosis. For the chronic space, we wanted the recoding to think about the stages of disease so that you could think about earlier and later stages of atheroma and think about it as a continuum. And that's where the second main strategy came along. We thought that it was time to think about atherosclerosis along the continuum of life and recognize that even before birth, people will have risk factors that are contributing to the chances of them developing coronary artery disease in future. That there are already studies that show us atheroma very early in life in children, and that of course that progresses over time. But that lifetime continuum is important, and currently our strategies look at the very best at looking at patients in their 50s and 60s. Most of our healthcare screening setups, or what we would call in the UK, our well women and well woman checks, don't start until people are in their 50s. And so it's already too late to pick up early atheroma. So we thought it was important to think about the opportunities at the various stages of life, and perhaps before birth, you're looking at maternal risk factors, things that increase the risk of a baby being born with a higher risk of coronary artery disease. In early life, there are obviously lots of impact you could have in terms of health life habits that our children need to develop across the world. In young life, you might be thinking again about promoting healthy lifestyles, but also on minimizing the various extra risk factors to cardiovascular disease, such as smoking. And then, of course, in adult life, it became really important to start to think about risk factor control. So you can see that the focus of what we would do would change as people progress through their life. That early on, it would be much more about prevention, and later on, we could be thinking more about diagnostics and therapeutics. Hopefully, all of this would start to prevent the chance of disease developing, of it progressing, and of it causing an acute coronary syndrome event. So what can we do today in our clinics? Well, I think the first thing we can recognize is that this is a preventable disease, and that actually we already know of many risk factors that contribute to the disease, and that if we start to act on those risk factors, we can prevent disease in a great number of our patients. This isn't a disease like cancer, where for many years we weren't quite sure why some people got it and some people didn't, although some of that's becoming clear. Actually, with coronary artery disease, in the vast majority of our patients, it's quite obvious what's caused their disease. And as I've shown you, there are lots of leading modifiable risk factors, things that we can do really early on to try and stop our patients developing this disease. That might not answer the full story. And as I said, there are probably many risk factors that we still don't know about, or risk factors that we don't know how to collect the data on. But for now, we know that there's some that we can act upon. And so we decided to think about risk factors. And we thought it was very important that we should diagnose risk factors early, find them in our children. Soon as possible, we work out when people might already be having risk factors that will contribute to the lifetime continuum of this disease. But it was also important to think about risk factors from a personal point of view. For one person, their LDL may be the biggest contributor. For the others, it'll be their hypertension. For some, it's purely their genetics. And there needs to be personalized approaches to these risk factors. We also thought, of course, it was really important to invest research in identifying novel risk factors, things that we still don't know about, because what we do know is that somewhere around 12 to 15% of people who have acute coronary syndrome don't have a modifiable risk factor that we can pick up. It might be that that's because there are other risk factors that we still don't know about. And then what was also important to think about was the association between those risk factors and outcomes. And sometimes that link's not that easy, but we need to think about research that pulls that together. Then we started to think about things that perhaps become more controversial. Maybe it's time to really think about early screening and detection programs. Now, this is interesting, especially on the back of some data that we had in the European Society of Cardiology last week. Early screening is very tricky. There's been lots of attempts at early screening programs where you might diagnose coronary calcium or perhaps even coronary atheroma and start to think about how that detection might have a way for you to basically modify the disease, perhaps by stopping its progression and therefore maybe having an impact on outcomes. The difficulty is that, of course, to design a study to do this, you have to have lots and lots and lots of patients, and you have to be able to look at patients over a very long term. If we were doing screening in children, we'd have to design enormous clinical trials with patients being followed up for many, many decades to really see if things had an impact. And you can imagine how hard that might be. But we thought it was important to start to think about the kind of research that would allow us to do this, and maybe it might rely on surrogate biomarkers. Perhaps we just look for regression of the atheroma itself, knowing that we can't ever design the study that's big enough to really pick up a reduction in myocardial infarction or death rates. But we thought it was important to think about strategies that would allow us to delay, halt, and reverse disease. And in thinking about screening strategies, we'd be thinking about strategies for early detection, but also perhaps strategies to really look at the plaque, decide on plaque burden and morphology, because we know that not all plaque is the same. In some patients it ruptures, in others it just develops slowly over time. And we need to understand for which patients there's what we call vulnerable plaque and for whom the plaque is relatively stable. And then importantly, some of that research is going to be very, very long term. And that would need global consortiums and lots of funding to think about how we do this over a very, very long term. And importantly, we'd have to think about screening programs across the world, because of course, not everywhere will we have the same ability to have the same imaging technologies. And how do we think about tools that we could develop that will allow broader access? But fundamentally, perhaps we needed to think about risk in a modern population, a Framingham program that was here in the modern era that would tell us about risk in this population and how we look for early detection. Then, importantly for the clinics, we need to be thinking about implementation, because what we know is we are pretty terrible at the moment at doing the things that we know work. And in our modelling, we saw that if we just started implementing some of the strategies that we already know and using the medications that we already have in our back pockets correctly to really target the risk factors in our patients, that we can reduce atherosclerotic coronary artery disease deaths by 82% by 2050. So you don't necessarily need lots and lots of new drugs and new tools. Just doing what we already know will reverse the tide. And importantly, we felt that we needed to address the global and local disparities in care and outcomes. And so that the research that we did would have to be practical and pragmatic, and that the more of the research that's done in places like Sweden needed to be adopted across the world, where we were able to do research within healthcare systems that was more cost effective, that was able to follow up people for a longer period of time, and where it was easier for patients to participate in research. That kind of research was very important to invest in. Because what we know is if we look at global deaths at the moment, you can see that the majority of the deaths are up there in the Northern Hemisphere. And then over time, you can see that that red progresses down into the Southern Hemisphere. And we see many more of the developing countries having the highest rates of atherosclerotic coronary artery disease deaths. And we know that in those regions, it's really hard to run big RCTs that are well funded by industry, etc. That requires lots of research infrastructure, but maybe there's a way to do much more pragmatic research in different areas, in other areas of the world. So how are we going to tackle those disparities? Well, one of the biggest aspects we felt was standardized data collection. Somehow we need a mechanism for getting data across the world. And that's been very, very difficult, even in the modeling of this commission. As I said, it was difficult to get data from everywhere. We need to be able to adapt the research methodology to local environments, and the big expensive RCTs can happen in certain areas, and the more pragmatic research can happen perhaps in public healthcare systems such as the UK or Sweden, where we've got access to everyone's data and the ability to do research in a different way to the way that they might do it in the US. We need to improve access to diagnostic tools, because at the moment it's almost impossible to get, for example, a CT coronary angiogram in Africa. But there might be new tools that we can develop over time. And then importantly, while we're doing all of this, I think what is important to recognise is that acute care and care for high-risk patients is still going to be important. And at the moment, it is really substandard in various areas of the world. It's not acceptable for there only to be one cardiac cath lab in Kenya that treats patients for primary angioplasty for a ST elevation MI. That care needs to be improved while we think about the longer strategy of preventing disease. And so then became the kind of moonshot ideas. So it is really important to invest in new therapies. It should be possible to think about therapies, a vaccine for atherosclerosis, if you will, that will eradicate the disease. And it might be possible to think about therapies that we can apply to the wider population. As I say, at the moment, we often think about things like my son having a vaccine for HPV, for a disease he will never get, right? To reduce cervical cancer in females. It's okay in certain areas of the healthcare system to think about vaccines on a population level, but we haven't really developed that sort of thought process towards atherosclerosis, and perhaps we need to make some of those bold statements. The early treatment of atheroma is incredibly important. And I think, again, we're going to be thinking about personalised care, novel therapies, something that could perhaps prevent this disease as patients go through their adulthood. And we need to increase the uptake of the treatments that we know. And of course, one of the things that's really important is to constantly reassess the treatments that we have. Because again, one of the things that we've started to realise is that many of the treatments that we have for atherosclerotic coronary artery disease, some of them were developed very early on in the disease, and things have changed. So, for example, most recently, we've been hearing about the reassessment of drugs such as beta blockers in acute myocardial infarction, drugs that were introduced at a time when the treatment for myocardial infarction was not as it is today, when it wasn't timely, when people didn't have primary angioplasty and early revascularization. And now when we reevaluate some of those drugs, they don't work quite as well as we expected in the new setting. And so we need to be able to have cycles of reassessing treatments so that we end up with exactly the right tools on our shelf to treat patients. So we talked about data collection, and I think establishing global data standards is going to be really important. But that will require resources and legislation, and of course it will require various healthcare bodies across the world to care about this disease, to be able to have accurate databases. And of course, some of this was so important, for example, in changing outcomes from HIV or malaria across the world. And once people were able to start to think about data as a crucial part of planning future strategies for healthcare services, they were able to have an impact on those healthcare services. And at the moment, this is really poor for atherosclerotic coronary artery disease. So when we think about data collection, we of course thought it was important that accurate disease monitoring was developed across the world. And in fact, it's poor all over the world. If you look at the disease monitoring in the US, it's very, very hard to get good data because, of course, the healthcare system is so fragmented. And without that data, we have no idea what the disparities are in terms of care and where healthcare services need to be improved. We need to have global data standardization, as I said, but importantly, we need to recognize that without that, there's a major impediment to doing any of the things that I've said as part of this talk. And we need more robust data systems, and where possible, they need to be joined up so that we can share our data across the world, because we need to establish that the variations are massive at the moment. And then also, we felt that it was important to really standardize the endpoints so that we could facilitate comparisons, so that we could understand what was the difference in MI rates in the UK versus South Africa. What was the difference in the US versus Sweden? At the moment, it's really difficult because the way in which we even collect these data points is different in different countries. So as you can hear, we've started to think about a whole kind of overview of how we think about atherosclerotic coronary artery disease, but also we thought that it would require an overhaul in the system and actually in the workforce. So at the moment, if you think about cardiology training across the world, it's really focused on the end-stage disease. We have lots of people being trained up in revascularization like me, or coronary imaging at a kind of late stage, etc. We're basing most of our coronary artery disease workforce in the hospitals. We leave prevention mainly to our primary care physicians and then to a few interested individuals, but our preventative doctors are not embedded within, for example, our heart team discussions as we discuss a patient who's got 3-vessel disease and needs coronary artery bypass grafting. We don't discuss how we might optimize their medication so they don't have another coronary event in the future. And we need to join up that system. We also need to acknowledge that the people who treat the end stage of disease, like me, the interventional cardiologist, need to be trained in prevention. And we all probably need to get to a point where we're starting to deliver more of this in the community. Importantly, it would be seen as a success of this commission if we were closing coronary care facilities because patients were not having heart attacks anymore. Imagine a scenario like we saw with HIV, where at some point, decades ago, we decided that AIDS was not an inevitable consequence of the disease and that you could prevent a patient from developing AIDS or an AIDS-defining illness as a result of their HIV. We closed lots and lots of infectious diseases units that were treating our patients with acute manifestations of HIV because we were able to prevent that from happening. And it might be the same in coronary disease. We might get to a point where we don't need these big coronary care facilities because, in fact, we're developing strategies to prevent disease so that patients don't come to hospital. So what does that workforce look like? Well, they need to start to understand that they are one big coronary artery disease workforce that's looking at prevention of atherosclerosis. We'll need to collect data on that workforce and understand where we need to pivot it and where we need to put more of our resources over time. And of course, in different countries, it will be different. And we probably need to think about whether we should provide healthcare closer to the patient. Now, this will need data around it too. In the UK, there have been lots of strategies around doing this, and many of them have failed. So we do need to work out how we do that well. Do we deliver healthcare best in a pharmacy, or has that got its own problems? Do we deliver it in a barber shop or, in a women's clinic? How do we do that for our patients? And then importantly, as we develop new workforce models, we need to evaluate them. And then comes perhaps the biggest and hardest one. We thought it was important to increase research funding. and that research funding needed to match the global burden of the disease. Now, one of the things that's important to remember here is it is possible for research funding to match the burden of disease. It does in cancer, it does to some extent in infectious diseases, but it doesn't in coronary artery disease. And in the UK, the stats tell us that the research funding is somewhere around that of mental health services at the moment. So we really need to increase the funding that goes on to this, and there needs to be lots of research priorities that are considered. So here we considered what was necessary for the general population, and here we thought the research that was needed was perhaps on data aggregation, on thinking about lifestyle and biology and risk factors. Then we needed to be able to have research that was aimed at individuals at risk, and maybe those patients needed to be part of studies that looked at non-invasive imaging strategies, early detection, how we might regress disease. And then importantly, in those with known atherosclerosis, these are the patients that we need to prevent, really tackle to stop them having events. And of course, we need to think about those patients in terms of that plaque composition and their risk of having events. And then it's not to say that we don't think there should be research in patients who have acute events. Those patients still don't have fantastic care across the world. And as I said, it's very heterogeneous. And we can certainly improve the diagnosis of acute coronary events and improve the timely and effective care that we deliver. So I'm going to come now towards the future. And I'm going to say that with our modelling, we came up with some sort of bold statements. We decided that to save 8.7 million lives every year, we needed to institute a few things. First, early detection and elimination of risk factors. Second, early identification and treatment of the disease itself. And the atheroma in and of itself, just making that diagnosis was an important endpoint for trials. And of course, we need to think about transformative discovery science. So looking for that big win, the big treatment that might be instituted globally that will prevent this disease. And then, of course, we need to be thinking about equitable access to care, because at the moment, many lives are lost because of the inability to access care. Now, the commission was, at the time of publishing, endorsed by the World Heart Federation. And I think they made some great statements, actually, and I wanted to show you what they said. They spoke about the word atheroma and what was in a word, and was it important to go from ischemia to atheroma? And they said it was important, as we defined in the commission, because at the moment, we think about ischemia. We detect the stenosis because it causes ischemia and a reduction in blood supply to the heart. But that in time, what we needed to do was detect the plaque itself, because that's what's central to the disease, and that's what allows us to think about treatment for the disease. At the moment, we test for ischemia because we think that causes events, and the higher the burden of your ischemia, the more likely it is that you'll have a coronary event. But in fact, we shouldn't just be looking at those patients who have a reduction in blood supply to the heart. We should be looking at everyone who might potentially have plaque, because we need to have strategies to modify or stabilize the disease and recognize that it doesn't have to lead to a coronary event. Revascularization strategies at the moment are all targeted around reducing ischemia, and we base everything on reducing symptoms and perhaps reducing coronary artery events. But actually, we need to recognize that revascularization needs to happen appropriately. It definitely saves lives in patients who are having an acute coronary syndrome, but in patients who have chronic stable coronary artery disease, all it can possibly do is improve symptoms. And so we should revascularize patients appropriately. And then importantly, we needed to get to the point of being able to change outcomes. And at the moment, we focus on symptom improvement, and we think about kind of hard endpoints, and I don't like that word, but myocardial infarction rates or death rates. But actually, that finding and modifying the plaque itself might become the outcome, because it'll be very hard to run the very big trials, as I said, that will show prognostic benefits, if you want to say that, within the trial, reduction in death or myocardial infarction rates within a trial. But if we can maybe start to think about surrogate endpoints of stabilization and modification of plaque, then we can run pragmatic trials that will hopefully allow us to institute therapies that will change long-term outcomes, but that might be difficult to study within one individual clinical trial. So what happens next? Well, the next step is lots and lots of stakeholder engagement, speaking to lots of people who are not necessarily cardiologists, but who are people who can really change the landscape of health services and health research funding across the world. Obviously, there's a whole piece around public education, and that's incredibly important because lots and lots of the risk factors that we can improve actually start at home with the patient understanding their own lifestyle modification that they can take on. We need global funding calls because lots of this research is really hard to do individually in countries or in institutions. It will need global challenges. And we need new research and, of course, evaluation of our success. So mostly I'd like to thank the commissioners, one of whom is obviously here in the room, who helped to put all of this together, but also to thank all of the funders who were part of putting together this commission. And what was important to say here is that one of the things around a commission is that you're not allowed to have funding from industry. So all of these funders were charitable bodies or local institutions who helped us to be able to meet and have thoughts about what we wanted to do and helped us to put together the infrastructure that allowed us to write the report. And then finally, I'll show you a QR code that allows you to download the commission. And I'll leave with a kind of final statement from the commission. So we wanted to put some parameters for success. And we decided that we would consider this commission to be a success if every acute coronary syndrome event was seen to be a failure of upstream care, not an inevitable consequence of a disease, but actually an avoidable and preventable moment. And actually what we wanted was to see this become rare and avoidable in the future because of transformative advances in care. And we hope, as I said, that we see coronary care units be something that we don't need as much of in the future because we're able to deliver care much earlier to patients that prevent them ever having that acute coronary syndrome event. And I'll stop there. Thank you very much for having me.
Thank you please. Thank you very, very much, Rasha, for this brilliant talk. We'll now proceed with Professor Johan Sundström. Johan Sundström, who is an excellent skier, but also a professor of cardiology in Uppsala since 2015. But more importantly, he used to be the inspector of Västmanland Dalarnas nation. That, I guess, is at the top of his CV. At least I would put it there. So I welcome Johan, who will talk about AI in ECG interpretation. But as Rasha also mentioned, he's on the Lancet Commission of Coronary Artery Disease as well. Please, Johan, most welcome.
Thanks, Jonas. Can I just start by saying how amazing it is to have Professor Al-Lamee in the room? Jonas asked me before summer, who's the leading female cardiologist in the world? And I said Rasha Al-Lamee, of course. So I don't know how much you understand how honored we are to have her here today. So thanks for that, Rasha. Thanks, Jonas, as well for having me here. So a small part of one of the last slides in Rasha's presentation was acute disease and how to find people earlier. And we've spent some time looking into that question. First, some of the stuff I do ends up being innovations that need to sort of move outside of academia. So I've co-founded a couple of companies. So our story starts here. This is the rainforest in Brazil. If you live here, it's pretty easy to get an ECG taken, but it's pretty hard to get a blood sample taken. It's also really hard to get the ECG interpreted by a cardiologist or a physiologist. So this is actually from the region Minas Gerais in Brazil that has about 22 million inhabitants. There's one place in the country, there's about 150 places where you can get your ECG taken, but there's one place where you can interpret it, and that's in Belo Horizonte, which is the capital of Minas Gerais. That's also the resident of one of the legends in global cardiology, Professor Tom Ribeiro, who's famous for his work in Chagas disease and other rare cardiological traits. So he has been instrumental in setting up a telehealth network. There's actually a journal of telemedicine, and it's described in there. So they start out with various ways of sending ECGs to Belo Horizonte. So it would be ADSL modems, and there would be, taking a photo of the ECG and texting it. They've ended up getting a structured system that looks the same around all of Minas Gerais, and they get between 5,000 and 7,000 ECGs to Belo Horizonte, to a team of cardiologists and physiologists who read these ECGs. So he approached a friend of mine, Thomas Schön, who's a professor of artificial intelligence in Uppsala, and he said, we have a bit of a problem, because what if the ST elevation is at the bottom of those 7,000 ECGs today? Can we get help in prioritizing how to read them? So this is a very well-cited paper, actually, by where Tom Ribeiro's son, Antonio Ribeiro, is the first author. That shows a successful training of an AI model on 2.5 million ECGs from this telehealth network. And of course, the labels, so in artificial intelligence, we get a lot of data, and then we get labels. So the label is the faucet, what's that? The ground truth in English, I guess. And we just give the data, the model structure, and the labels to the AI. And then we have it train itself to figure out what the label is. Is it a heart attack or not, for example? So these labels in this study were the physiologist or the cardiologist readings of the ECG, their diagnosis. So human labels, basically. And they got pretty decent performance on some of the more common ECG traits, the 6 or 7 ones, like atrial fibrillation, AV blockage, etc. So we inherited the structure of the model because Thomas Schön is a friend of us, and in Uppsala, it's really close between the Faculty of Technology and the Faculty of Medicine. So we have sort of joint meetings, and we're like, well, how about ECGs? And I'm like, well, of course we have that. So we've used that same model architecture in another data set that was collected by Martin Holtzman, mostly, dear friend and colleague who sadly passed a couple of years ago. So what we had was 8 million emergency department visits from mostly the region Stockholm and region Västra Götaland. And in these 8 million ED visits, about 500,000 ECGs were taken for the usual reasons: breathlessness, chest pain, palpitations, etc. So what we started out with was using the human labels in Rikshia, the part of Sweetheart where you classify hospitalization episodes as a STEMI or a non-STEMI episode, or not myocardial infarction episode. So we started out training the same kind of model. It's a CNN network, a convolutional neural network model. It's the ones that are used for all kinds of image readings by AIs. So it's a pretty sort of off-the-shelf model architecture. So we started out with the STEMIs and the non-STEMIs, and then everyone else who was in the coronary care unit during these years. So that was a sample of about 22,000 or something like that people. And the models just didn't reach the performance standards that we had seen in other papers. So then we added on 470,000 healthy ECGs to the model. And the model became fantastic just by reading 470,000 normal ECGs, which is sort of amazing to me. I don't understand how that works. So this model that could classify between STEMI, non-STEMI, and non-infarction, it got a C index of 0.99 for STEMI. So the C index is a measure, it's the area under the ROC curve. But to put it in other terms, it's if you have 2 patients in front of you, one of which who has the myocardial infarction and one who hasn't, how often would the model guess which one has the highest risk? So this model would guess the right person with a STEMI 99 times out of 100. What do you think us doctors have? What do you think our C index for myocardial infarction is? For STEMI, cardiologists for a STEMI, what's your C-index, Rasha? Oh, you're optimistic. It's around 75%. So we make the wrong guess, the wrong call in 1 out of 4 cases, and this model does it in 1 out of 100 cases. So it's just amazingly much better than humans. So these are human labels that it's been trained on. But and this is what some of the ECGs looked like. We picked out some of the ECGs that had the highest probability of being a STEMI. This we would agree with, but then what we did was ask the model, could you please tell us where in the image you saw that it was a STEMI? And this is called a GradCam plot. You should ask for that in every AI paper that uses images, because sometimes there are some cases where in chest X-rays, for example, the GradCam plot jumps up and highlights the place where the age of the patient is, the personal identification number. And of course, cancers or heart failure or whatnot would be more frequent in older people. But this GradCam plot highlighted these sections of the ECG curve. So the Q wave we would agree with, a little bit of blue here in the ST segment, but mostly it used the end of the T wave for its diagnosis. And that was jaw-dropping for me. I mean, of course, we could agree, sort of in retrospect, that, well, maybe there aren't any other ECG diagnoses that look like this. Maybe a myocarditis has a bit of a softer angle here. I don't know. But I think this was an eye-opening moment for me, because now we can say that the AI is teaching us humans how to read an ECG, and I thought that was sort of a step forward. This is the same thing, but for non-STEMIs, and it actually had a C-index of 0.85 also for non-STEMIs, which we humans need a troponin for. Okay, but we don't just have the human readings of these ECGs. We know what's been going on in this patient's coronary. So these are people doing Rasha's job, but in Uppsala, Kasper and Giovanna. And they know what the coronary tree looks like. And this is all captured using these standardized data models that you asked for in Sweetheart, and specifically in the SCAR part of the registry. So we know who had an occlusive myocardial infarction, who had a total occlusion that was acute, and who had a heart attack but no acute occlusion. So we applied the same model structure for this, and this, of course, is a superhuman capacity of the model, right? Because we humans can't really say if this is an occlusion, myocardial infarction or not, because there are no labels for that. This is just a distribution. This is just a heat map of the distributions of where the acute occlusions were. I don't know if you can see, but the left main artery there doesn't have a lot of acute occlusions in it. And why do you think that is? Is that sort of safe from occlusions, from plaque ruptures? No? Because they die before they get to the cath lab, right? This is, I mean, if you look on Wikipedia about survival bias, you get this image of a plane returning from English Channel work in Germany, and they looked at where do we need to fortify the airplanes, where do they get most bullet holes, and of course the people, I mean the bullets that hit the crucial parts of the airplane, those planes didn't make it back. So you would fortify the wrong parts of the plane if you just went by that map. So that's the case with the left main occlusions as well. They typically don't survive. It's not entirely unfilled in. I mean, there are a few of them, but they're not a lot of them. So this is just ongoing work. It's under review at the moment, and you can see how this model can actually, with a C-index of above 0.95, sometimes 0.99, show you that there is an occlusive myocardial infarction going on, and it can also show you in which vessel the acute occlusion is. Because you can have, I'm not an interventional cardiologist myself, but I would guess that there are a couple of chronic occlusions, and the patient with chronic occlusions also have a high risk of acute occlusions, same disease. And sometimes it's kind of hard to understand which is the acute occlusion here. Do we need to work up the whole artery tree, or is it enough to just do the culprit lesion, and which one is it? So this might help the angiographer to steer the wire to at least prioritize them in some kind of order. So that's ongoing work. Again, this is of course superhuman. We humans can't really challenge the model. We can't say if it's right or wrong because we can't see this in the ECG. We did other fun stuff. This is all just ECG-based stuff. We wanted to sort of practice our model building, and we did probabilistic models instead of just classification models, yes or no. And it turned out that this model, same basic architecture, you just exchange the head of the model. That's what they call it, the sort of when it produces its prediction. We could change the head from a binary classifier, heart attack, yes or no, to something that's probabilistic on a continuous spectrum of these electrolytes. And the model became quite decent at guessing the potassium level within the normal range of potassium. I mean, we all know that if you have super high potassium levels, you'll get a U wave and you'll get weird ECG changes. But it was pretty decent at guessing your potassium even within the normal range. We thought this was purely academic fun, but Tom Ribeiro says, well, if you're in Minas Gerais and we want to put you on an ACE inhibitor, we'll have to get your blood sample in 2 to 4 weeks to check that you didn't get hyperkalemia from that. And it's easier to get an ECG. It's hard to get a blood test. So this could actually have clinical implications in low resource settings. Also, of course, in the ambulance, understanding that this is a hyperkalemia that's treatable already in the ambulance could be useful. So fun. We also have other superhuman tasks that we're throwing on the model now because we know what happened with everyone in this data set. So we're now training it on all of the other scary stuff that goes on with people in the emergency department. Again, just using the ECG, we get pretty decent performance in finding the heart failures, and actually the pneumothorax as well is one of the better ones. So this work is ongoing this semester. I mean, it's sort of conceivable, right? I mean, a pneumothorax, you would get different electric properties, but we just don't have any human criteria for what the ECG would look like then. Okay, that was the end of sort of our stuff. I'll just show you some of the stuff that's been going on in the literature in the last year. This paper got it into Nature. This is an American endeavor looking at structural heart disease and ECG signs of that. Again, superhuman tasks because humans, we don't have an ECG criteria for an LVEF of less than 45%. This model got a C index of 0.90, which I guess is good, right? It's good because we humans are pretty bad at guessing LVEF as well. So that's fun. I thought the most interesting part of this was this figure. This shows the accuracy of doctors using the ECG and guessing all of these structural heart disease traits. And you can see that doctors were right in two cases out of 3, maybe. The AI was correct much more often. That's the green bar. But then when you showed the prophecy of the AI to the doctor who'd already made his or her guess, they didn't change their mind enough. So the combination of a doctor and an AI was actually much worse than the AI alone, which is just, this is important because if you have something that a human can't read in the ECG, you'll need some good, solid RCT evidence to change people's minds because I'm going to show you how to do that, actually. I think it's in maybe the next couple of slides. Okay, this is also what's going on at the moment, larger and larger training data sets. There are a lot of public ones like Mimic4 and PhysioNet and also the PDB-XL. And of course, this is the Brazilian 2.3 million ECGs, but they're now up to 4 or 5 million. So we're still sort of collecting all these ECGs. So that's really a current trend. And also, how do we train our model? So I told you we used the CNN model, the usual image classification models, but now we're seeing increasingly use of transformer models like ChatGPT, because you can think of the ECG as language, of course, because stuff happens in sequence, and what happens now is in some way determined by what happened before. So ECG data are pretty good for transformer models, actually. Electronic health records data are not good for that because there's so many silent intervals between occasions. Between events in the medical charts. So loads of transformer stuff happening, which is fun. Okay, so how do we test this? So before I show you that, I got a phone call from Mora, which is sort of a rural, very small hospital, and they had a visit from the company PM Cardio. Has any one of you have had a call from PM Cardio? No? It's one of the American groups that are really good at doing this stuff, and they've commercialized their models, and they say that we can get you an occlusive myocardial infarction model, and you can get it for free for 3 months. Do you want to go for it? And I mean, if they were selling a model that was a STEMI, non-STEMI model, at least a STEMI model, it'd be easy to have it highlight STEMIs because the doctor could take responsibility for that patient and say, well, okay, so it says STEMI, I didn't catch it, but now that you say it, maybe that's a STEMI. So a doctor could sort of override the decision or at least take some responsibility for it. But if the prophecy is this is an occlusion, an acute coronary occlusion going on here, but you can't see it, then how is the doctor going to be able to take responsibility for that decision? So the people in Falun who do the angiographies, the PCIs of the Mora patients, they were like, are we going to activate the cath lab in the middle of the night just based on what the computer says? And also not activate it even if the doctor thinks that there's an occlusion because the computer says no. So I think for some of these superhuman tasks, we need RCT level evidence. The typical of diagnostic procedures is that you just need to show something like the C index, and then it's bang, you're out in the clinic. So this is a really cool group in Taiwan that have done 2 trials. I'm going to show you both. So they got consent from 53 doctors at the Department of Internal Medicine. I don't know if you can read, the lettering is pretty small. They didn't get consents from the patients. They just got consents from the doctors. The doctors were equipped with smartphones. Actually, they use their own smartphones. And they agreed to being texted with SMS text messages when the ECG algorithm said this is dangerous. Okay, so this first model was a model that provided the risk of mortality within 1 year. So a 1-year mortality model. It's actually not that great. It has a C index of about 0.8 or something. Still interesting, of course. But so the doctors in the intervention group got pinged. They got a text message if the AI saw in the ECG that this patient has a high risk of 1-year mortality. And these were patients in internal medicine wards and emergency departments. And in the control arm, you didn't get the text message. So what they found was a hazard ratio of death, in hospital deaths and up to 1 year of 0.83. And this is a really powerful treatment, isn't it? I mean, you would approve a medicine that reduces mortality, total mortality by 17%. And it's a decently powered trial. So I think this is an interesting sort of proof of what AI readings of ECG can do. To be fair, it's paired with the whole text messaging here, but I mean, why not? It's still an ECG model, I think. This is the same team doing the same study, but now with cardiologists, and now they get a potential STEMI text message. This is their STEMI model that actually has a worse C index than our models has, but they have now they've put that into work, and during 1 year they got 42,000 ECGs, and in the intervention group, they texted a cardiologist that's on call that this is a STEMI, and of course they did nothing in the control group. In the control group, the standard of care here is that there's an emergency physician taking care of the patient, and of course they would see the STEMI and call the cardiologist. So part of the win here is probably that the text message to the cardiologist was faster than what the emergency physician was. So this is door to balloon time here. So you see that in the intervention group, the door to balloon time was 82 minutes, and it was 96 in the control group. So 40 minutes faster door to balloon time just based on this AI ECG reading. I think that's pretty nifty. So this is, I think, this is a great example of large pragmatic clinical trials with outcomes that we care about using AI ECGs. I've spent my 20 minutes. I'm not going to show you that, how not to test, but we can talk about that over dinner. I'm following your example in this QR code to Sommarprat. We have a series of summer talks at Akademiska sjukhuset in Uppsala, if you fancy listening to more of my AI babbles. Thank you. It's in Swedish, Rasha. The talk is in Swedish, but feel free anyway. We can talk about it later.
Thank you so much, Johan. I promise everyone here that when there is a reliable AI model, I will always use it for my ECG interpretation. I will never overrule it, I promise. Okay, now we're moving to our last speaker who volunteered to give this talk with very short notice. I'm extremely happy to have Magnus Bäck, Professor of Cardiology at Karolinska Institutet with us. Magnus trained with the legendary Göran K. Hansson and then went on to do a postdoc at Hôpital Bichat in Paris, then went on to become professor at Karolinska in 2016. He will give a talk about a study which was just published in JAMA about the role of Helicobactery, in a way, among patients with myocardial infarction. A warm applause for Magnus Bäck. Thank you so much.
Thank you very much for this kind introduction, and thank you for giving me the opportunity to present these results for you today. These are my disclosures, and as you just heard, this study was published and also presented at the European Society of Cardiology exactly 1 week ago today, so on 1st of September. And we're moving focus a little bit now. So what we heard in the first talk today is a lot about the primary prevention and the increasing risk in this context. But if we instead look at the secondary prevention, so what we do after a myocardial infarction, the development looks very promising. So this looks, if we look back for the past 30 years, these are Swedish data from Swedheart, just to see the prognosis after a myocardial infarction, that it is decreasing. So we're good at this in improving the prognosis and decreasing the risk of a recurrent event. But this comes, of course, at a certain price with the treatments. And one of the disadvantages of the increased antiplatelet treatment are the increased bleeding complications. So with a decrease in mortality, we see an increase in bleeding complications after a myocardial infarction. And among the out-of-hospital bleedings afterwards, the most common is upper gastrointestinal bleedings. And I spotted on one of the slides in the previous talk, actually, gastric ulcer, which is part of what maybe can predict it from an ECG. But what we did here was to look at the risk factors for upper gastrointestinal bleeding, and the risk factors we were interested in here was Helicobacter pylori infection. So the Helicobacter infection can be diagnosed with a urea breath test, which is a bedside testing. And our aim here was to introduce Helicobacter screening as routine care after myocardial infarction in order to detect those that are carriers of Helicobacter and treat, eradicate this infection. We had to give antibiotics and proton pump inhibitors to prevent the development of upper gastrointestinal bleeding as a complication of an acute myocardial infarction. So to answer this question, we designed a nationwide, cluster randomized, crossover, registry-based clinical trial. In total, 18,000 patients were included, and this shows the design of the trial in this that we included 35 Swedish hospitals that were clustered into different clusters, and this was based on the PCI networks where we have patient transfers within the clusters. The randomization is not on the patient level, it's on the cluster level. So these hospitals were either randomized into having Helicobacter screening or the usual care, meaning that it would be a routine that every myocardial infarction patient should be screened for Helicobacter with the urea breath test. This screening period was 1 year, and we then have a washout period for 2 months without the study intervention, and then there was a crossover. So those that started with giving usual care added the Helicobacter screening in the second period. And those that were screening in the first period actually stopped and continued with the usual care. And this was made possible since we provided from the study the screening equipment to the hospitals that were screening and then removed the screening equipment, so it was no longer possible to do the screening routinely in the cardiology wards. We then follow all patients for another year after the last patient was included. And the endpoint here was to follow up and look for upper gastrointestinal bleeding to see if we could reduce that, but also potentially have effect on cardiovascular outcomes, since it could potentially increase the compliance to antiplatelet treatments. This is registry-based, so the patient sample was defined from the Sweetheart registry, where we have all the admissions and discharge for acute myocardial infarction. And we then linked all this data to the national patient registries, where we also follow up with the diagnosis of an upper gastrointestinal bleeding. So this shows a map of this nationwide study and all the different hospitals that were included in the clusters, and the color just shows in what order this screening took place. I think that some of you maybe in this room or online have been involved into this and participated in making this study possible. And it's a very wide inclusion criteria. It should be a non-selected myocardial infarction population. The only kind of inclusion criteria was the fact that those were adults and they had a personal number, personal identity number, making it possible to link with registry data, and that they were discharged alive with a diagnosis of a type 1 myocardial infarction. And we had no exclusion criteria. And the whole study design has been described in more detail, and this can also be found and published before the study results were published. And before we started the study, we also did work on seeing what would be the sample size estimation and also the feasibility. So we performed a pilot study to check the feasibility of bedside urea breath test in acute cardiac care, and also to establish the prevalence. So we did this at Huddinge Hospital and Södersjukhuset, and we looked at consecutive acute myocardial infarction patients, and we got the prevalence of Helicobacter pylori infection. And it was 20% of all myocardial infarction had an active infection diagnosed with a urea breath test. And the second part was to look at the incidence of upper gastrointestinal bleeding after myocardial infarction. And we performed this in Sweetheart, looking at follow-up data, and we could set the incidence of the upper gastrointestinal bleeding in this population. So based on this, we did the sample size estimation based on the prevalence and the expected incidence with 2 years follow-up. And we assumed that the intervention could potentially offer a 30% relative risk reduction due to the screening. So we did simulations based on these data, and we came up with a number of patients that potentially should be included. But importantly, this is an inclusion, is not on the patient level, it's on the cluster level. So it determined the time of screening into 1 year at each arm of the study. So in the end, I already showed you we include a little bit more than 18,000 patients. And this shows the baseline characteristics, quite typical, expected, and well-balanced between the two groups, those receiving usual care and usual care plus screening for Helicobacter. And among the characteristics, the most important, the result of the screening. So we performed screening in the screening arm, and of course no screening in the usual care arm. And we come up to about 70% of every myocardial infarction had actually the screening performed. And of these, we had the testing positive, which came up with a prevalence in this sample of almost 24%. And quite importantly in this is that the intervention was the screening, and the actual prescription of eradication therapy, antibiotics, and proton pump inhibitors was at the discretion of the caring physician. But there was a very high compliance to this, and we're almost at 100% that received eradication therapy. When we look at the discharge of these patients, they have very good numbers in terms of their secondary preventive treatments, high rates of statins, aspirin, and general the treatments that are prescribed when you're discharged after myocardial infarction. But what I want to just draw your attention to is that it's quite common to prescribe proton pump inhibitors, even in the absence of the screening. So almost half of the myocardial infarctions are actually discharged with a prescription of proton pump inhibitors. And now let's move over to the results. So when we look at the incidence of the upper gastrointestinal bleeding, this shows the control group receiving usual care and no Helicobacter screening. And we have a total of 336 events and 4.6%. And then in the group that received screening, we see less events and a lower event rate in this group. And the rate ratio was 0.9, corresponding to a 10% decreased risk, but this comparison did not reach statistical significance. Looking at the secondary endpoints, we see no effects on the different cardiovascular outcomes between the group receiving usual care and those receiving usual care and Helicobacter screening. If we dig into different subgroups of this and to detect possible heterogeneity in the data, we have predefined the subgroups to compare. And if you look at this slide, you will see that there is all a tendency to have a beneficial effect on the side of screening being better, but with confidence interval that are crossing the measure of unity. There are, however, some subgroups that may be of importance here. If we look at the patients that have anemia, those that have either mild or moderate to severe anemia were the ones that actually had a significant benefit of Helicobacter screening. We also observed a significant protective effect from upper gastrointestinal bleeding in those that have renal failure. All this was in the intention to treat analysis. And as I said, we had a compliance of around 70% in terms of screening. So if we do a per protocol analysis, meaning that we're looking at those that were actually screened going through the intervention, we see also a protective effect, which is stronger, but again, not significantly different. And also looking at the group that was actually positive and their benefit of having been detected and treated. So to conclude this study, this is a nationwide cluster randomized crossover registry-based clinical trial, and it's a complete unselected population of acute myocardial infarction, but adding routine Helicobacter pylori screening to usual care did not significantly reduce the risk of the primary endpoint, which was the upper gastrointestinal bleeding. But we did see a 10% protection, which was not significantly significant, but it could have clinical relevance. And we should think about that the prevalence in Sweden is lower than it is in several other countries. We have, as I pointed out, a high prescription rate of proton pump inhibitor. And we also, in this study, identified subgroups that potentially could have a benefit in having Helicobacter screening, those with anemia and those with renal failure. So with this, I also, of course, want to thank everyone involved in this study. Robin Hoffman and I were co-PIs of this study, and we have several help of several. And as I said, maybe some of you here or online actually were part of making this study possible. And an important point is also that the funding was completely free from industry or for-profit organization and completely funded by national and regional foundations. So with this, thank you very much.
I'll invite the two of you to sit over here with the panel, please. Kan ni sitta här? Kör för. So we move the camera somewhat. Fine. Okay, excellent. So first of all, thank you very much, Magnus, for everything. And then also for your talk, of course. And I'll start by asking the audience if you have any questions for the panel. Please introduce yourself with name and where you come from, and then your question.
My name is Ganesh Acharya. I'm a professor of obstetrics and gynecology. You'll be surprised at Karolinska Institute here. My question first to Dr. Al-Lamee is, you discussed about the sort of identifying plaques early. I am a gynecologist. Of course, I would not know all things about cardiology, but do you have anywhere that you screen for the plaques to decide what kind of plaques end up in complications? And I did not hear anything about prevention strategies that you use. Are there any particular prevention strategies that have shown to be beneficial for that?
Yeah, thanks.
I have another question to you, of course, but I will come back towards.
Thank you. Thanks very much for the question. So there are many different screening strategies. The one that's probably most established is the use of coronary CT. And there are studies out there that show that the use of coronary CT means that people have more preventative medications than one of the commonest, the most cited ones from the UK. It's called the Scott Hart study. The preventative strategies, yes, there are lots of things, but statins are probably the most commonly prescribed medication when people see plaque within the coronary arteries. And what we know is that the prescription of statins can obviously reduce cardiovascular mortality rates in the long term, and there's lots of evidence around that. The key question, I guess, will be, how early do you do the screening? How often would you do the screening? And of course, the problem with some of these imaging tools like CT is they come with their own risk. Radiation risk, the potential that you pick up other things that you weren't expecting, that leads to over-investigation. And also the worry that when people see coronary plaque, they decide they need to revascularize that patient, or they send them for more procedures. So the screening isn't straightforward, but that's where the research is needed, really, to work out whether we can do anything. The other thing to add is that there are now increasingly some new tools that look at the vulnerability of the plaque. There are some promising work within CT itself, so certain markers of plaque that's more likely to rupture in the future. But most of those aren't mainstream within our services to use, but they might be in the future.
Am I allowed to ask Rasha questions?
Yes, you are.
Thanks.
Please.
Did you follow the presentation of the Dan
Yeah.
2 trial?
So that was really disappointing. So there was a recent trial that was done in Denmark, basically presented at ESC last week, that looked at within a healthcare system such as Denmark, calling patients up, well, via the healthcare records, basically, patients were either to come in for a screening. It took about 11 minutes. They would have coronary calcium score and a very brief consultation. And then obviously with the results of that, you'd institute more prevention. The problem was that the results were not as we expected, basically. They didn't show a reduction. Now, the follow-up was only 7 years. So as I was saying, to probably reduce mortality rates, you need large numbers of patients. I think the number of patients in each arm was about 7,000. So again, it probably needs to be many, many more thousands of patients, and it probably needs to be for longer. Then the argument comes, well, how many patients do you treat with a statin to save one myocardial infarction? I don't know. And that's where we had lots of conversations, as Johan will remember, as a commission. But the data currently isn't there to necessarily support big screening programs. But maybe we're looking for the wrong thing. Maybe the trials that we've designed haven't been big enough or long enough.
I have to say that as a non-cardiologist, hearing that you follow up, like 7,000 people for 7 years and you don't see a difference,
Yeah.
you start to ask yourself, okay, so how big is the difference?
Yeah.
Are we really going to treat this group?
So that's a very important point. But again, sometimes I bring that cancer analogy back in. Somehow we think that a sudden cardiac death or an acute coronary syndrome, these are calamitous events for those patients when they happen, right? And the strategies that we're thinking about to reduce those events are relatively low intervention, low cost, and institutable potentially at scale. So do we treat everyone, or do we say, using other research, who are the higher risk patients and how can we pick them up much, much earlier? How do we know that someone's risk is high at a much earlier stage, and maybe they're the people that we treat? I don't know. And that's where the research needs to come.
I'd like to turn to Magnus now. I once had a paper with a fairly important paper with a p-value of 0.006, which was a bit kind of annoying. Now you had 0.10, I think, and I guess you still inside here believe there is an effect, but it was just slightly smaller than you had anticipated, and you couldn't, show it. So, what's in the future? Are you going to actually treat your patients with this kind of screening, will you? Or will you just restrict to those with kidney disease and anemia? What will you do?
Yeah, and I think this is an important question that to interpret the results of the study. So what we know that under these circumstances in a non-selected population and having it as a routine screening, routine intervention, we cannot prove that it has a beneficial effect. But we do see certain tendencies that could be developed. But as I said, there are also other settings, but no recommendations can be made based on these results.
What about, did you perform any post-hoc analysis in the group of, what question was actually, what about those who did not yet have a PPI? I mean, that would be a group I'd myself be quite interested in. Let's say I was a general practitioner. I see this patient, he's had a myocardial infarction, no one has done the testing. Should I look for Helicobacter pylori?
Yeah, so we have several of analysis coming from this study. So this is part of what we will look into. And it is important also if you want to kind of change the recommendations for using PPI. And if we want to decrease the use, this could be one way to decrease the use of it. But again, the study was not designed that way.
Okay. Rasha, I'm a pediatrician. I see a lot of obese kids. Okay. Should I tell them, you should really lose weight because I know someone who believes this is dangerous in 50 years to come?
Yeah,
should I tell them?
Absolutely. I mean, obesity increases risks in many, many ways, right? And so outside of coronary artery disease, there are many diseases that are more likely in these kids as they get older. But the question is, do you tell the kid you need to lose weight, or do you tell the system that the food that we provide in school, the cost of fast food. And I mean, perhaps these are all much more about public healthcare measures than they are about individual kids and their families. And that's where I think it makes a difference. So a difference that was made in the UK some time ago was a system, the Sure Start system, that taught kids from lower socioeconomic classes, and more importantly, their families, what diets were important and how they were fed. And those things made a real difference on childhood obesity in the UK. But unfortunately, many of those systems have broken down. And so we don't have a lot of that now. But that's where I think it matters. Yeah.
So what's on your top list for the next year? This is what I will help the pediatricians with to prevent future coronary artery disease. What will you tell your British colleagues, pediatricians? This is what you should do.
So I think when you see a kid who's got high BMI, they probably come from a family who also has high BMI, increased cardiovascular risk. There are often other risk factors within those families. I see it a lot when we have, you'll do a cath lab procedure in the middle of the night on a patient with ST elevation MI. They're very often not infrequently, sat next to their son who will be also carrying many of those risk factors. And we don't counsel that son. We just tell them, I'm sorry, your dad had a heart attack today. But I think you as a pediatrician needs to be thinking about that wider family and thinking about risk prevention within that family. Of course, at the moment, we're not able to institute risk prevention strategies medically in those kids, but we certainly can give them lifestyle advice that would make a difference.
Mm-hmm. Do you think we should have a sugar tax in Europe?
Yeah, I do actually, yeah. And I think ultimately what we saw was, banning smoking in restaurants was probably one of the best public healthcare measures for reducing, improving cardiovascular outcomes, far more than giving medications. So yeah, I do.
I think in the work with this commission, I went through the reports of what countries had sugar taxes in place, and there were about, so this is last year, about 55 countries in the world who had that. Sweden had a proposal for that a couple of years ago, but it was killed by both the left and the right side of the politics.
We might discuss this later, Johan. But I'm turning to you again, Johan, and you've been quite active in the debate about hypertension. I mean, hypertension is one of your things. So you want to lower the blood pressure levels to treat more people. Okay, will that? I mean, there are pros and cons of medicalizing people, and you're planning to medicalize a large proportion of the Swedish population, are you?
Yes.
Yes. Okay. Yeah.
But
go on.
but also, I think the challenge is to do this because we know that it's going to save lives, quality of life, suffering, and money. Because I was part of the national working group for hypertension in the kunskapsstyrning thingy, and we calculated that to just follow the European, the American, and global guidelines of lowering blood pressure below 130 in high-risk people. That would cost about 4 billion Swedish kronor, and we would need a number of more general practitioners. We would save that just with the first hospitalization that we will prevent in these people, and the second and the third and the fourth heart failure hospitalization, for example, are just a bonus. So I have a problem with the Swedish healthcare law says that you should treat the person with the highest need, but Swedish healthcare law also says that you need to prevent disease. A lot of primary care now are saying that we can't work with preventive care because we need to treat the people who are already sick. And I just think that's kind of cynical, just postponing care until it's sort of too late. I think that was the gist of the Lancet Commission as well, to try and make these rare diseases instead of diseases that everyone needs to have. So I think it's economically feasible. I think we advocate also, as in the Commission, a layering of care so that the person with the lowest education and lowest salary basically does most of the work. The patient needs to do more work themselves. Home-based blood pressure is what we advocate for a lot in the guidelines. So it doesn't have to be super expensive. We don't have to medicalize a lot of people because there are other stuff we can do for the blood pressure.
I'm a hospital-based specialist, and I can see that over there where the GP is working, the hospital-based specialists are throwing more and more guidelines do more, work harder, work longer, more hours, and it simply doesn't work out. So is it time for the cardiologist to actually step out of hospital and do some prevention?
Yes, please. If I could do prevention 100% of my time instead of acute care, I'd love that. That'd be my dream. Also, I think
are you quite lonely about that opinion, or
I think so.
Are you representative of cardiology?
Rasha just said that too.
Yeah.
Let's make these rare diseases and let's just do prevention. I think competing in who has the most guidelines to read is silly. That's just a super stupid competition. Just because someone has calculated how many guidelines primary care doctors need to read. We have an equal amount of guidelines. There are so many different heart diseases, and we're very guideline heavy.
I know.
So we're going to win that competition if it's a competition. I don't think it should be.
Can I just comment also?
Yes, please, Magnus.
Because I think it's just important that the way what you just said is that we should be rethinking. So we should be rethinking that we should concentrate on atherosclerosis as the disease. So then we should skip the term prevention. It's treatment of a disease. And of course, those treatment recommendations will be different for a youth to an older and certain different age limits. But I think that's the thing. If we would say that atherosclerosis is a risk factor for having an event, and we want to treat atherosclerosis.
No, but I mean, but then is it time for you to climb down from your cath labs and actually do some work?
I think
with the general public.
So we made a big piece around the workforce, right? So the workforce, you're right. I mean, I'm an interventional cardiologist. What people think is cool is being in the cath lab and, doing lots of intervention. So we do need to train our workforce to understand that your pathway into cardiology is not necessarily the right thing for the patient. Is not that we're all trained to the end stage of the disease, but that we're actually trained to do things upstream. And to your point, I think the word we speak about it in the commission, the concepts of primary and secondary prevention, we felt were wrong. By the time you're at secondary prevention, as you said, these patients have already had the event, right? Yes, we can have impact, and we have an impact on people having recurrent events. But what we should have done is make sure they didn't have that first event in the first place. And so it's thinking about atheroma, thinking about the diagnosis and treatment of atheroma, and actually, just as you said, not putting the onus of that on the primary care physician, because that's where we've probably gone wrong.
So what did the primary care physicians in your commission say about your proposals?
Well, it's a good point. We didn't have primary care physicians in the and maybe we should have, and that I take that responsibility. We did have lots of very thoughtful discussions about health services, and we did have people who were non-cardiologists who were health services delivery people. So, there was some of that aspect, but you're right, we didn't have any primary care physicians.
Johan?
I think we have a particular problem in Sweden with. Yeah, sure. Sorry, this is just so important and so enthusiastic. Anyway, in Sweden, the task of primary prevention falls on primary care. A failure of prevention incurs costs in acute care or hospital care, and the incentive structure is just misaligned. If I worked in primary care, I'd be doing what they do too. I'd say prevention can wait because I have people knocking on the door, and I need to my key performance indicators say I need to answer the chat with the patient more efficiently. So the people who seek care will be my top priority, and I don't want to also, as you said, I don't want to medicalize everyone. So prevention or opportunistic screening is not for me. If we could align the incentives so that the costs and the wins of primary prevention end up in the same place, I think we would see quite different activities going on. And I'd be happy for hospital-based doctors to do prevention. We actually do a lot of screening studies at the moment and try to initiate primary prevention. Another option, of course, is the American system where the primary care physician gets to pay the hospital bills as well. And I think the incentive for prevention would be different if the cost of that stroke or heart failure falls on you.
We move over here. Yes, please. Your name and your affiliation, please.
You're Roland Müller-Suhr, and I'm clinical physiologist and nuclear medicine. And I have a question to you, Johan Sundström. You seem to be very happy about your artificial intelligence to diagnose a myocardial infarction. Now, and EKG. Now, I am still educating EKG, and it's not so simple. People are not really good on EKG diagnosis, and the artificial intelligence cannot be responsible. You named it very little, but that is a most important point, I think. Artificial intelligence cannot be responsible, and every time we use artificial intelligence, I think we should have a mark. This is done by artificial intelligence, not by any other point, and that we cannot use that. We have to be responsible to. We can use it to look at it as the computer diagnosis of EKG, but you have to be is good, and you have to see it's okay. And I think it's so important to make this open for everybody to know, because we would like to use artificial intelligence. I think the general practitioners would like to make it. They don't like to diagnose EKG. They like to have these help, but I think it's very problematically. And now your diagnosis that was quite simple. This was not very difficult. The EKGs were difficult. That is the problem, not esteem elevations, myocardial infarction. That is very simple.
Great. So many good points in there. I'd just like to address a couple of them. So first of all, we do have a part of my research group is actually philosophers and ethicists who work with the ethics of AI in medicine, because it's a hard question. And we've done interviews with doctors and nurses and patients, and doctors always state that on the question of who's responsible, the doctor is always responsible. That's what the doctor is saying. So I think we need to worry there. I don't think it'll be like in self-driving cars where, oh, Tesla is responsible or someone else. It's going to be the doctor. And I think that's what they feel, because we use a lot of stuff that we just don't understand. I don't know how a CAT scan works. I don't know how the central laboratory works. I trust those things. I make my medical decisions based on those prophecies anyway, or predictions. So I think we're going to have to put some trust in the machinery, but we will have to, what I talked about in the last point, when there are situations where a human can't override the AI's decision, or we can't really see what the computer has seen in the ECG, we're going to have to demand higher levels of evidence to show that using this algorithm improves care, saves lives better than not using. So I think that's the lesson for us all, to demand those kinds of trials before we unleash these algorithms in the hospital.
Please.
My name is Patrick Olin, and have been working with pertussis vaccine trials for some 20, 30 years, and before that, pediatric endocrinologist. And I enjoyed very much all of the talks tonight, and I would rather suggest that your complexity of the global situation is so enormous that somehow you have to try to combine what you are doing, all three of you, using different approaches in studying. The randomized clinical trial is a basis, but it has to be followed up by population studies. And we have to combine those lines of evidence in order to be able to draw conclusions much earlier. And I think it's a good example with the human papilloma vaccine, virus vaccines, where I thought it would take decades to know the answer, and we seem to have the answer within a few years. And I think that also the AI opens opportunities, but still have to be looked very cautiously on. And also I enjoyed Magnus Bäck's presentation on the cluster studies, where you can utilize much easier large populations by studying the clusters, where you actually are not doing the randomized clinical trial, but still get a very good answer, although in this case, negative. Thank you.
Okay, while we wait for more questions, a short question for you, Magnus. Sweetheart has been an enormous success, you know, with all the trials. Do you see it as a limitation that you don't really apply your trials to prevention, but only treatment? So how can, or do you have any plans for changing that?
So it's a good question. Yes, of course, it gives the possibility of studying the patients who enter into the registry, at the time of a myocardial infarction, at the time of the event. But it could potentially also be used as a follow-up on other interventions, which is done, meaning that if you appear in the registry, meaning you would have the incident event. So it is technically possible. If it is organized, or if an intervention is organized on a population basis. And I mean, the outcome can always be followed in the national registries, which is done also in screening studies, but with more, it would give more information on the type of event and other parts of risk factor handling.
Please.
Just curious. You talked about superhuman tasks, and you showed that ejection fraction was detected by ECG correctly, right? Is that understood? I understood it correctly, right? So, I mean, it may be so, but does it then, you know, you showed also that ST segment elevation, you can actually ask the AI, then it will show, here I showed the ST segment elevation. So what was the place in ECG that it shows that it predicts the ejection fraction? So then we would learn from AI perhaps to predict ejection fraction looking at ECG in retrospect, right? I do not know how an ECG can be interpreted to predict ejection fraction as a human.
I agree, and I haven't seen their GradCam plots. We try to employ them in all our studies, but I would say that they're not that clear as the ones that I showed you. They're much more confusing to look at, to be fair, and it's hard for us to learn and to formulate criteria based on that. That said, I don't know if you're aware, but in your ECG machines, you use the Glasgow Royal Infirmary algorithm from the mid-90s, and in terms of heart attacks, is wrong one case out of 3. So there's a huge room for improvement for some of the tasks that these rule-based systems employ.
Yes, certainly, but you know, like predicting ulcer by ECG would be a little bit illogical, isn't it? Although it's sure that it can perhaps do that, you know. So I'm just thinking about how we should actually look at this. We have, as obstetrician, a huge problem. We had a huge randomized trial, international, showing that artificial intelligence to detect acidemia using, you know, the ECG parameter that have been used quite a lot in clinical practice without any evidence does not work. You know, and so it could not detect anything, although we say that, okay, yeah, ST segment elevation, it has a, you know, ST segment can say everything about fetal health, so we cannot, in retrospect, if we cannot ask AI, why do you say this happens, and you detect it? It's just a chance occurrence in a way, right? How do you see it?
Well,
I don't know. You know?
My take on it is that, well, some things we might get to understand. We might get to learn more, such as the end of the T wave and the STEMI. But other things, I just don't understand what it does. How does it know if a person in sinus rhythm is going to get AFib later? How does it know the age of the person, etc.? So at some point, you just go, you know what? I'm just going to go with the flow here and trust the computer, because now we're just throwing everything in the kitchen sink onto these models, and they're amazing at stuff we never thought it would excel at. So and again, I don't understand how a CAT scan works either, and I just accept that, and I'm ready to take responsibility anyway. But I need other kinds of evidence, RCT level evidence.
Please, name and affiliation, please.
Hi, my name is Rasha Al-Lamee. I'm a cardiology resident here in Stockholm. My question is for Professor Al-Lamee. do we need to see a stenosis or atheroma in order to treat the patient, or should we just arbitrarily use an age limit such as age over 40 and treat everyone with statins, as Professor Magnus Bäck at Imperial Colleges once suggested?
Yeah, so we had a lot of conversations about this. The analogy we kept making of, should we put statins in the water, right? We put fluoride in the water. So do we, so you're quite right. I mean, is there, we don't have the evidence to know that we should do this, but the question is, should we wait for the atheroma or should we try and treat before the atheroma? My feeling is we should be trying to treat before atheroma develops. That's actually very, very important. Having said that, we've already talked about the ethics around it and how do you do this at scale and how do you even convince people to do it? You said, how many people would you need to treat to do that with to save one death? Again, I keep bringing the analogy to infectious diseases, to cancer, because there are other diseases where we have seemingly been happy to believe that if we treat at a population level to prevent only a minority of people from having a disease, that's okay. But we don't seem to have done that with coronary artery disease. And I think we should have that debate, basically. Would I take a statin before I had atheroma? Yes. Am I taking a statin before I have atheroma? No. But, I feel like that is where we should be going, right?
Yeah, at dinner, I will ask more people, are you actually taking a statin? I'm very curious to know. I won't do it now then. I want to turn to Rasha. You talk about equity. Before this meeting, I was actually attending a meeting about colorectal cancer screening. We discussed, socioeconomic differences, gradients actually also in Sweden when it comes to survival and when it comes to screening, etc. So how will you decrease inequality, inequity in cardiovascular disease? How can we?
So that's probably the most difficult question of the whole that we tried to answer within the commission. One of the major difficulties is even if we started a national screening program, we know that the uptake will end up being in people of higher socioeconomic class. We always know that that's in fact, some of those screening programs end up encouraging more inequity in a system. I don't know the answer. One of the answers, I think, in the end has to be where we can institute public healthcare measures, we do it, because when the fast food's not available or it's too expensive, that it doesn't get bought. Where we can institute, if we had the vaccine for atherosclerosis, we would institute that and the vast majority of people might take that up. But inequity is one of the biggest problems, I think. And I don't know what we do about it, because I think we see it in every healthcare condition and we haven't overcome it.
I mean, you have inequity, we have in Sweden inequity, but then we have actually the majority of the population globally who have perhaps a living standard which is far below that of the UK and Sweden. How do you plan to reach these to rise the cardiovascular, improve coronary health?
So this is where we spoke about cheap solutions that can happen at scale, that can be instituted and are easy. PCSK9 inhibitors, fantastic, but they're incredibly expensive and we can't access them in many of the developed world systems. So they are not the vaccine for atherosclerosis. Whatever it might be has got to be something quite different.
What could that be?
Well, maybe Johan can come in. I think one day whether it's a genetic modification tool, whether it's, the equivalent to a vaccine, I think that may be what one day comes, but cleverer people than me will discover it, I think.
I'll let Johan answer first and then we'll have one more question.
Just a comment. You had a picture, global death from the carrier in 2050. And that is a very funny picture. The Russians were very bad today, were very good in 50, and also America very good in 50. How can you calculate that?
Yeah, so that
is a speculation. You know what Trump is doing? He's doing the opposite. Yeah, this picture is totally absurd.
So look, this was we had a modeler that worked with us in the commission. The modeler based things on the trajectory of healthcare systems in various countries, the amount of funding that was being put into them, the amount of prevention that was already happening. and how those systems would change over time. Of course, this is modeling and it comes with those caveats, but it was based on global burden of disease data, the trajectories that we've already seen, and extrapolating that things will go in the same trajectory. So you're quite right. If you suddenly, disbandon the healthcare system in the UK, things might be very different. But we had to base it on the trajectory things have already been on and where they go in the future.
Now I leave it to you, Johan. Please, Johan.
I was just going to say that there's stuff to be learned from the work of the WHO. They have tried to, in a structured way, implement cardiovascular prevention guidelines in various countries, a lot of low-resource settings. And they've come up with success stories, and they're summarized in a pamphlet called the WHO Heart. So the Heart is a sort of abbreviation of whatever. And there's stuff for us to learn from that. So some of the stuff that's been going on in the hypertension sphere at the moment is this trying to structure caregiving to the person with the lowest costs, basically, and try to move stuff out into society, out to the patients. And that has come from good examples of low resource settings. You can't afford a doctor, so you'll use the second best or whatever, which actually happens to be more effective sometimes. I think we could take a leaf out of that book, and I think that's going to help with equity.
I'm actually closing this session with my final question to the three of you. If you could wish for one thing to happen in the next 10, 20 years to reduce coronary artery disease, what would that be? Short answer. I'll start with Rasha. One thing you can wish for.
So I think we need more research. And so if I'm going to ask for one thing, it would be that the amount of research funding that's available globally matches the global burden of disease. And then I think maybe we might get somewhere.
Magnus?
He's also finding fast tracks of trials of new concepts of to prevent cardiovascular disease and to go from the actual bench results back out to clinical practice.
Johan?
On my top of my wish list is taxes on salt, sugar, and fat.
Okay. We're going to talk more. Thank you so much. I'd like to give the panel an applause. And with this, we're closing this evening seminar, and those who have registered for the dinner are welcome outside. I know that the Swedish Society of Medicine wants to take a photograph of us four before we move out to the dinner, so please stay. Thank you very much.
Nice to meet you.